So my topic is heart failure in neonates and infants. Ross classification was modified from NYJ classification. There is class 1, no limitation of symptoms. Class 2, mild tachypnea or diaphoresis with feeding. Class 3 is infants with growth failure and marked tachypnea or diaphoresis with feeding. And in older children, it is with marked dyspnea on exertion. And class 4 is symptoms at rest, such as tachypnea, retraction, grunting, or diaphoresis. So what are the etiologies of neonatal heart failure? Primary cardiomyopathy, dilated hypertrophic LVNC, non-compaction, and restrictive cardiomyopathy and arrhythmogenic right ventricular dysplasia. Inflammatory cardiomyopathy, myocarditis, rheumatic heart disease, Kawasaki, small vessel vasculitis, infectious, endocarditis and sepsis. Metabolic causes are there: fatty acid oxidation defect, carnitine-dependent fatty acid transport defect, disorder of mitochondrial metabolism, glycogen storage disorder like Pompe, mucopolysaccharidosis, MPS, and infant of diabetic mother. Toxic causes are there: calcium channel blocker toxicity, anthracycline toxicity, and ionizing radiation. There are vascular causes: extracardiac AP malformation, congenital cutaneous large hemangioma, hypertension, arrhythmogenic causes like SVT, atrial flutter, congenital heart diseases like left-sided and right-sided heart diseases, shunt lesions and obstructive lesions. And other causes are twin transfusion syndrome, sacrococcygeal teratoma, myocardial ischemia, perinatal hypoxemic ischemic injury, coronary thrombosis, Al-Kappa, and pulmonary hypertension. So it may be in structurally normal heart, myocarditis, cardiomyopathies, myocardial ischemia like KD and Al-Kappa, arrhythmogenic causes and drugs, toxin, and sepsis. So in cardiomyopathy, pediatric cardiomyopathy, generally uncommon but life-threatening disease affecting 1 in 1 lakh children. In American Heart Association, there are 4 stages of treatment in cardiac heart failure, in heart failure of cardiomyopathy: stage A, stage B, stage C, and stage D. I'm not going into details because a lot of videos are there for clinical discussion. Lower quality of evidence from primarily single center study and trials are there because pediatric studies are not in larger trials. Few large and multicenter trials are there in children, but most of the studies are taken from the adult trials only. And AC inhibitor and beta blocker for heart failure with DCM children has not been shown to improve transplantation-free survival. So this is another issue in heart failure guidelines which are taken from adults. Furthermore, symptoms and outcomes did not improve in a randomized control trial of 161 children with heart failure who received carvedilol in addition to AC inhibitor. So these are the drawbacks, how the adult studies are, the children protocols are taken from adult studies, and these are not fruitful in children. Relative to adult heart failure population, there are additional barriers in clinical trials in children also. Inadequate statistical power associated with small sample size, phenotypic heterogeneity, age-specific variation in pharmacokinetics and pharmacodynamics. There are larger variation in sizes of the children from neonate to larger child. So the larger variation in sizes of the child cannot predict the proper dosage of the different dosing of the drugs for heart failure. Children lack different comorbid conditions like adults. So adult drugs, adult doses, and adult different medications of heart failure cannot be applied to children like adults. What are the unique characteristics of heart failure in children? There are some inherent differences in myocardial adaptation secondary to DCM. Death or transplantation usually occurs within 2 years after presentation of DCM, suggesting that many children and adolescents have advanced disease at presentation. Children downregulate both beta-1 and beta-2 adrenergic receptor, whereas adults downregulate only beta-1 adrenergic receptor. The effects of medical blockade of already downregulated beta-2 receptors are unknown. So carvedilol effect on children are unknown. Less than 21 years old children, DCM causes are taken, DCM cases are taken from autopsy only. 0.65 new cases per 1 lakh per year when looking at the new clinical diagnosis. DCM and HCM occur at nearly equal rates. This is the cardiomyopathy causes. This is dilated cardiomyopathy, hypertrophic cardiomyopathy, and LV non-compaction. Up to 20% children with newly diagnosed DCM have family members with positive genetic or familial screening result. Recently, familial DCM have been shown to occur in 30 to 40% cases with autosomal dominant inheritance. Birth syndrome, which is X-linked syndrome associated with short stature, cyclic neutropenia, and 3-methyl gluconic aciduria. HCM, pediatric HCM more diverse with genetic syndrome and metabolic abnormality, contributing up to 43% of diagnosis. As we know, Pompe's disease, lysosomal storage disease, these are all non-sarcomeric causes. In contrast to adult, those are sarcomeric causes. And in Noonan also, RAS MAP kinase pathway is affected. As this case is restrictive cardiomyopathy in a 3-year-old child, which was eosinophilic myocarditis. All TDI values are less. And LV cavity and RV cavity all are full. So we diagnosed this clinically and with echo as Loeffler syndrome, but cardiac biopsy could not be taken. LV non-compaction. It is also called as persistent fetal myocardium, prominent trabecular and intertrabecular recess, thickening of myocardium into two distinct layers composed of compacted and non-compacted tissue. Non-compacted tissue is 2/3 and compacted tissue is at least 1/3. Mortality is high. Preserved ventricular function, volume overload and pressure overload. Left to right shunt, as we all know, common atrium, AV canal defect, large PDA, AP window. These are the common causes of heart failure in small children. And admixture lesion, TGA with increased pulmonary flow, TAPVC, obstructed TAPVC, tricuspid atresia with increased pulmonary flow, and valvular insufficiency. These are the main causes of heart failure in children. And anemia, large AP malformation, fluid overload. These are the causes of heart failure. And left-sided lesions, hypertension, tight coarctation, critical aortic stenosis. These are the causes. And right-sided lesion, critical PS, severe pulmonary hypertension. These are the right-sided causes. And primary pulmonary hypertension and Eisenmenger syndrome. These are the right-sided heart failure causes. So in case of critical AS, severe coarctation, severe LV dysfunction, balloon dilatation of aortic valve and coarctation in cath lab can be done. Critical PS, balloon pulmonary valvular plasty can be done. Obstructive TPVC, urgent surgical correction, L-kappa, urgent surgery needed. Common atrium, large VSD amounting to single ventricle, PDA, large PDA, large AP window, truncus with increased pulmonary flow may need urgent surgery. These are the different causes in different days of life, already discussed. So what are the investigations we must do? The main investigation, CBC, CRP, hepatic function test, thyroid function study, vitamin D3 level and serum calcium. We must not forget ever the reversible causes first. Reversible causes are anemia, hypocalcemia, the anemia, hypocalcemia and hypothyroidism. We must not forget ever. If we forget these and we run behind the cardiac causes, then we may miss these common causes. And we have saved many children with these reversible causes with just simple treatment. And NT-proBNP, serum I level, this can be done, and serum carnitine level. The serum carnitine also is a reversible cause, and we have seen these many cases in our trial and in a series. Carnitine is also a reversible cause. Whole exome sequencing can be done in case of genetic causes. This is a case of Pompe disease. We can see the whole myocardium is filled with hypertrophied muscle tissue, cardiac muscle tissue. And Pompe disease, the infantile type of Pompe disease is mostly severe, and the child present with normal child at birth, but doll-like faces, and gradually the child becomes floppy, and the heart becomes enlarged, and the ECG becomes cannot show. The large voltage ECG and biventricular hypertrophy, biatrial hypertrophy is there. This was a case of small ASD, but the child came with severe respiratory distress and breathlessness. And to our surprise, we have seen the child having atrial flutter. As you can see in the echo also and ECG also, we need to admit the child, and we plan for cardioversion, DC cardioversion, but the parents did not give us the consent, so we started metoprolol infusion and then oral. The child sent back home. Another child, 2-month-old baby, brought to ER with severe breathlessness for last 2 weeks. You can see there's large PDA, 7 to 8 millimeter PDA, left to right shunt, and AML A2 prolapse with severe MR. Another child, 3 years old child, post-operative VSD patch closure, but there was a Swiss cheese VSD. So the child had residual multiple VSDs, as we can see. The child presented with fever, breathlessness, and heart failure features. We have seen the tricuspid valve regurgitation, the tricuspid valve vegetation. You can see. So it was a case of infective endocarditis, and we did accordingly.
We are possibly having Dr. Maity with us. She couldn't finish her presentation due to some technical glitches. So, Dr. Maity, if you can kindly resume your presentation from exactly where you had paused last time, so we can finish it first and then we will take some quick question answers.
Thank you, ma'am. This is the case of cardiomyopathy. You can see the LV dysfunction, and there is severe MR. And in every DCM cases, we need to see the coronaries, see the coronary flow. So it is not a case of L kappa. Again, it is a case of DCM. Initially came with myocarditis. Then it did not recover and became a DCM. Again, we had to rule out L kappa, coarctation of aorta, and severe aortic stenosis. We ruled out. It was a case of sinus venosus ASD, SVC type. With severe LRTI, it came with heart failure. Although SVC type ASD doesn't come with any heart failure symptoms, but it had severe bilateral pneumonia, so it came with heart failure. This patient, outside it was diagnosed as L kappa, but here we diagnosed as not as a case of L kappa. It was a case of DCM. You can see the flow, coronary flow. And it was a case of L kappa actually. RCA is dilated, and see the reverse flow. 3-year-old child with L kappa. See, the flow is coming from pulmonary artery, left main coronary artery. So the flow is blue. ECG showing electrical alternates. And the child presented with heart failure symptoms. And it was a case of tamponade. We need to put a pigtail catheter and drain the fluid. This case came with heart failure symptoms. And we could not find heart in the left side. It was on the right side post. And there was left side massive pleural effusion and collapsed left lung. And heart was normal. This is collapsed left lung. Again, coronary normal. This was severe myocarditis and NT-proBNP was more than 30,000. Drop eye positive. Newborn came with heart failure, large PDA. SVT and PJRT, another forgotten monster type of AVRT, is long RP tachycardia with dilated cardiomyopathy features. But any DCM drugs doesn't help here. Only the ablation helps here. And we must not forget the syndromes in pediatric heart failure: Noonan syndrome, Down syndrome, associated with severe PS, AV canal defect, and Williams syndrome with supravalvular pulmonary stenosis, Noonan syndromes, Bacterial anomaly, Williams syndrome, supravalvular pulmonary stenosis, and supravalvular aortic stenosis, Treacher-Collins syndrome with multiple PSD, ASD, Marfan syndrome, and last but not the least, heart defect. This patient has a TOF, ectopia cordis, presented with heart failure with severe anemia. TOF can present with heart failure with severe anemia. There are multiple lots of slides I cannot show here. Atrial flow regulator is there, device therapy for severe pulmonary hypertension, for failing fontan and severe pulmonary hypertension, cardiac resynchronization therapy for failing heart, PA banding for left to right shunt, and increased pulmonary flow in case of cyanotic and acyanotic heart disease. In case of increased pulmonary flow, non-pharmacological intervention are there on the way. Genome editing fleet, CRISPR-Cas9 is a revolutionary gene therapy on there. Berlin Escort devices, as we all know. There are multiple sizes of devices, but here it is not available. In Delhi, in some institution, it is practicing, but it is only a bridge therapy, a bridge to cardiac transplantation, as small hearts are not available. So it is a dream till now to us. First successful pediatric heart transplant was done in 1984. 2014, 3D printing of the heart was used as heart transplant. Heart-lung transplant is being done in South India also for primary pulmonary hypertension, Eisenmenger syndrome in unrepaired CSD. Challenges are there for cost, organ donation complexities, retrieval not well equipped, waiting list is too high, and waiting list mortality is too high. So long ways to go in pediatric cardiology. Thank you. More things were there to discuss. Sorry, I could not discuss. Thank you for shortage of time. Thank you. Thank you.